today I'm going to be talking a little bit about the vascular pathology of the spinal cord and the spine. And as you will see, the emphasis is going to be at the beginning a little bit in the anatomy, because the understanding of the different pathologies of the spinal cord is closely related to a good understanding of that anatomy. Many of you have seen, especially some of the residents, some of the angiograms, and know that it's not easy to understand them. And it is fundamental to have that detailed knowledge of the vasculature of the spinal cord to really know what is going on when a patient has an abnormality and be able to plan the adequate treatment. I don't have any disclosures to make for this presentation. Now, that understanding of the anatomy of the spinal cord has a long trajectory in history, and it is important that we remember those that were here before us that contributed significantly to understand what we know today of the spinal cord and its vessels. Henry Duret was the first one who described the anatomy of the vessels of the spinal cord, and he is, of course, more known for his work in traumatic brain injuries and elevated intracranial pressure. But probably one of the most remembered physicians that contributed in the understanding of the anatomy of the spinal cord was Adam Kiewicz, who described that famous artery that we all know that irrigates the thoracic portion of the spinal cord, and that becomes the center of the attention for many of the endovascular procedures, and is also very important in other surgical fields like cardiothoracic surgery. However, the understanding of what was wrong when somebody had vascular abnormalities of the cord has not been that clear. At the end of the 19th century, Gaup and some other German pathologists described the first cases of autopsies finding these dilated vascular structures in the spinal cord that they call hemorrhoids of the pia mater. And it was not very clear if those were arteries, veins, how those things happen. And the treatment of them also was quite misunderstood. At the beginning of the 20th century, Charles Ellsberg performed the first resection of one of these arteriovenous malformations. And what he did actually was to cut the veins that were coming from this vascular abnormality. And in his first case, he was successful. However, he tried several cases after that doing the same, and all of them failed. He actually had significant bleedings, the spinal cord suffered tremendous strokes, and then the treatment was not clear. Why, in some circumstances, just cutting the veins seemed to be working, while in other ones was making the things worse. Also, very famous for the eponym of that carried their name, Charles Foix and Theodore Alajuanin describe some changes that were induced in the spinal cord of necrotizing myelopathy that was in correlation with the finding of dilated vessels that appeared to be thrombosed. And the Foix and Alajuanin syndrome became a popular description of patients that have this kind of progressive myelopathy that goes very rapidly, usually males over the age of 60, and that is associated with vascular abnormalities, as we will discuss. Some of the most important advancements in the angiographic understanding and the anatomical understanding of the vascular pathology of the spinal cord happened in France, and Pierre Michon described a case of acute subarachnoid hemorrhage associated with an AVM in the spinal cord, and he coins the term the coupe de poignard, that basically means the stab in the back. That is the typical presentation of a patient with an arteriovenous malformation. This sudden onset of pain, that is, they actually almost always say the same, is the feeling of being stabbed in the back. And this is important because as we see, these lesions become more and more complex. Some of them present with bleedings, like those that produce the coupe de poignard. Some other ones present with a progressive myelopathy, like the ones described by Foix and Alajuanin. Bergstrand, Hook, and Littval were the first one who performed angiograms where the abnormalities in the spinal canal were observed. And this is actually from the original paper from 1958. These were done just with injections in the aorta, and the arrows in their publication are pointing to this aneurysm, as they describe it, of the spinal canal. And after the lack of success of Ellsberg, Taylor was able to report 6 cases with a little bit better outcome in 1964. And he actually pointed to the right direction in the surgical treatment of these lesions. One of the things that he commented in this presentation was the fact that when you are resecting vascular abnormalities of the spinal cord, special attention is to be taken to avoid coagulation in excess and to try to use sharp dissection around these lesions, trying to preserve as much as possible the structure of the cord. Now, almost at the same time, the influence of the angiographic school of the Lariboisière Hospital in France had taken some advantages of advancements in techniques and catheters. And in 1968, Dorfman published the first embolization of an arteriovenous malformation of the spinal cord using little stainless steel pellets. And the influence of all the group directed by René Jinjiang in the Lariboisière is fundamental because thanks to their detailed anatomical and angiographic studies of patients with arteriovenous fistulas and malformations is that we have a better understanding of how they behave, the types of malformations and abnormalities that you can find, and they open doors for the options of treatment, including both a better understanding of what to do in the surgery and which were the options of the endovascular approaches. Based on that, Dorfman, Dichiro, and Omaya were the first one in presenting a classification of these arteriovenous fistulas and arteriovenous malformations. And since then, many other people have tried to do modifications. Probably some of the most popular was recently one published probably 5 or 6 years ago by Spetzler. And basically what we're going to do today is refer to the same basic concepts and try to clarify the spectrum of pathology that can be seen in the spinal cord, but based in the same elements that Dorfman, Dichiro, and Omaya described at the time. Undoubtedly, the use of the intraoperative microscope changed the surgical approaches and the surgical success for these lesions. And Jasserhill described the fundamental steps and pearls in the technique that is necessary for the resection of the spinal AVMs. And later, in the late 70s, Mallis had also a significant amount of work describing detailed surgical techniques that are the basis of what we use today to resect surgically these lesions. From the endovascular perspective, it has been a series of successes and failures. And at the beginning, the use of particles, following a little bit the tradition of what Dorfman had done, actually produced not very good effects. And the use and the introduction of the liquid embolic materials was very important in changing what we can do from the endovascular perspective to treat these lesions. And Alejandro Bernstein led the efforts on those kind of embolizations. And most recently, with different and more controllable embolic materials like the ethinyl vinyl alcohol, Andrew Molyneux and some others have published several cases of use of these materials in the embolization of the arteriovenous fistulas and malformations. So even though the historical tradition seems to be long, extends for at least almost 2 centuries, the real understanding of what is going on is still quite complex. And when you get patients with vascular abnormalities of the spinal cord, you may receive a different series of denominations depending on who is reading these films. And the understanding of really what is happening is fundamental to decide what to do for them, what could be the role of the endovascular therapies, what could be the role of surgery, and what type of surgery or endovascular treatment you have to do. So in order to understand that abnormality, is fundamental to have a very clear understanding of the anatomy of the vasculature of the spinal cord. And the best way to approach the anatomy of the spinal cord is to think about it in 2 different aspects. One is a longitudinal aspect of all the vessels that are going to irrigate the cord, and the second one is going to be a segmental approach. From the longitudinal approach to the understanding of the anatomy of the spinal cord, you need to remember that the cord is going to be irrigated by 3 spinal arteries, 1 anterior spinal artery and 2 posterior spinal arteries. But that concept itself is actually a little bit imprecise because you don't get such a thing as an anterior spinal artery. What you get is multiple small segments that are located anteriorly in the midline that in the majority of cases are connected to each other and that form an artery. But in many cases, they are not connected, and what you have are small segments of those vessels that constitute what we call the anterior spinal artery. So the anterior spinal artery doesn't necessarily have continuity. What it is an addition of segments that in many cases can connect, but in some it may not. On the other hand, the posterior spinal arteries work more like a plexus, really, where they are frequently connected and they have multiple tributary vessels that are going to form them. And this is very important because it determines the risk that we have when we do either embolizations or surgical treatments for these patients. Now, from that longitudinal aspect, there is usually very well-established patterns of how these arteries form. But they almost kind of remind you a little bit of the embryologic development. And as you remember, all the arteries of the body initially are plexuses, and some of them form these tubular structures, the majority of them. Some of them remain with this character of multiple possible feeders, and there is a lot of variability in how they can form. In the cervical portion, the anterior spinal artery is formed usually by the contribution of two branches that come from the intracranial portion of the vertebral arteries that originate just before the vertebrovascular junction. However, they are not always present. Usually one of them is dominant, the other one is not there, and they may not be together at all. So you may not see any of those traditional vessels that I always paint in the junction of the vertebral arteries. Then you get between 4 and 6 vessels that are going to come from different vascular structures of the neck that are confluent and form the anterior spinal artery in the cervical portion. The majority of times they come from the vertebral artery, but they can also come from the ascending cervical artery, that is a branch of the thyrocervical trunk, or from the deep cervical artery, that is a branch of the costocervical trunk. They also can come from the ascending pharyngeal arteries from the external carotid artery, and they also can come from the occipital artery. And this pattern is quite variable. Of all those vessels that you have in the cervical portion of the spinal cord contributing to the anterior spinal artery, probably the most constant is a large artery in the lower portion of the cervical region, usually coming from the vertebral artery that is called the artery of the cervical expansion. But other than that, you may have them from multiple branches from the carotid or the other subclavian branches. Once they come to form the anterior spinal artery, they have this pattern of either a Y shape or a T shape that is painted there in the center, and they contribute to form then that tubular structure in the front of the spinal cord. For the posterior spinal artery, the variation is even more. They are usually between 11 and 14 branches in the cervical portion that come equally from the vertebral arteries, from the ascending pharyngeal, the ascending cervical, and the deep cervical branches. Now, in the thoracic spine, the thing is a little bit different. And the characteristic of the thoracic spine is that you don't have enough contribution to form the anterior spinal artery. There is usually only one large branch that comes from one of the radiculomedullary branches, usually one of the segmental arteries of the thoracic spine, so it's basically a branch of one of the intercostal arteries. That is the artery of Adamkiewicz. The majority of times it's not in the side that is in the drawing, but it's on the left side. The majority of times is between T8 and T11, in 80% of times, but it can go as low as L2, and it can be as high as around T5 or T6. And the issue is that this is the only contribution that you get for all the extension of the thoracic portion of the spinal cord to the anterior spinal artery. On the back, you have, again, multiple radiculomedullary branches that come from multiple of the segmental arteries in the thorax and the lumbar spine. And finally, the lumbosacral portion is formed again by a plexus that is even more complex in what is being originated from, but that has the good result that usually there is a very good irrigation to the conus, coming from multiple radiculomedullary arteries that follow the nerve roots and that are going to form a basket of vessels in the tip of the conus. As a result of this vascular distribution in the longitudinal axis, there are some portions of the cord that then get very good irrigation and some other portions that don't. And that determines an area that is the area of watershed in the longitudinal axis of the spinal cord for the anterior spinal artery that is usually around the T4 territory. And that is the area that is more prone to suffer of ischemia if, for example, somebody has a very low blood pressure during a procedure. And that is also the one that will suffer most likely of ischemia if you compromise any of the branches that are forming the anterior spinal artery. Now, from a segmental perspective, the things go a little bit differently. And this slide is very important because it will allow you to understand a bit what happens when we do an angiography. The branches that are going to contribute to form the anterior spinal artery and the posterior spinal artery, all of them come from the segmental branches of the aorta. And these segmental branches are going to originate usually from T3 all the way down to L3. Above T3, what you get is branches from two arteries that are called the supreme intercostal arteries that usually go and irrigate the vertebral bodies and can have contributions to the spinal cord, but usually they don't. Between T3 and L2, what you get are small direct branches from the aorta that are usually together and located posteriorly in the aorta that are called the segmental arteries. And those segmental arteries are going to have three main branches that you can see here on the right. So the segmental artery is going to produce a lateral branch that is going to follow in the thoracic spine the rib and is the intercostal artery. It has a medial or posterior branch that is a musculocutaneous branch that goes to the skin and the muscle. And it has a mesial branch that is the vertebral artery or a spinal artery. This actually is going to divide in three branches. One branch that goes behind the vertebral body and frequently connects to the other side, that is the retrocorporeal artery, and a posterior branch that goes to a lamina. And then it's going to produce a small branch that in the majority of cases is going to behave like in this drawing on the left side. This branch is a radicular artery that goes either with the anterior nerve root or the posterior nerve root, and that usually ends there. So those are basically the three branches that you will get in any segmental artery. However, when the radicular branch extends all the way into the spinal cord, it can connect either to the posterior aspect or to the anterior artery, and it's going to form the anterior spinal artery or the posterior spinal arteries. When this happens, then this middle branch is not a radicular branch, but it's called a radiculomedullary branch. And Adamkiewicz is basically a large radiculomedullary branch in the thoracic region. In the cervical spine, all those branches that I was showing are radiculomedullary branches that are forming the anterior spinal artery. This curve is also important because, as you know, the aorta is located slightly towards the left of the vertebral bodies in the chest, and then becomes a little bit more medial in the abdomen. So what is going to happen is that the right branches are going to be long. They're going to be located towards the midline, and the left branches are short, and they are located posteriorly in the aorta. Now, once you have the anterior spinal arteries and the posterior spinal arteries, the concept of the segmental anatomy, what applies to is the fact that they are not going to be necessarily communicating. As we mentioned before, you can think about them almost as different segments. And what they're going to produce is a series of branches that go then into the axial plane, into the spinal cord, to provide the irrigation of the spinal cord. So every anterior spinal artery is going to have multiple sulcal arteries that go into these sulcus of the anterior aspect of the spinal cord, and that then are going to produce this pattern of branches that radiates in a centrifugate manner. And some of the posterior spinal arteries are going to contribute to form a plexus that goes around the spinal cord that is called the coronal plexus, and that is going to irrigate part of the surface of the cord. So this diagram explains a little bit that. You see on the right side the usual radicular artery that doesn't reach the cord, the retrocorporeal branch of that segmental artery. On the left side, you have a radiculomedullary branch that goes not only into the nerve root, but reaches the anterior spinal artery and the other retrocorporeal branch. This anterior spinal artery is going to produce a sulcal artery that then produces a radiation of vessels that irrigate the cord in a centrifugate manner. From the posterior spinal arteries, you have radiculomedullary arteries, and these are going to connect in a pattern that is very variable, but that usually is richly vascularized and produce irrigation of the cord in a centripetate manner from the periphery to the center. This then produces two different areas that are going to be irrigated in a different manner. The anterior portion of the spinal cord, and actually 2/3 of it, are going to be irrigated by the anterior spinal artery, while only 1/3 is going to be irrigated by the posterior spinal arteries. And it's kind of an unfortunate thing, because if you think about it, the anterior spinal artery is the one that has less branches. It's only one vessel, and this one is the one that is going to be in every segment irrigating the majority of the spinal cord, while the richly plexiform posterior spinal arteries only irrigate the surface of the cord, which generates a second watershed area, this time not in the longitudinal axis, but in the axial axis, that is this region in between the irrigation of the anterior spinal artery and the posterior spinal arteries. And this has been detailedly studied for many years. This is from René Jinjiang, and they were doing in cadavers this microangiography, and you can clearly see how the anterior spinal artery produces the sulcal artery and these trees of multiple vessels that clearly irrigates the majority of the spinal cord, while the coronal plexus of the arteries irrigates only the surface of the cord, and that generates in the different areas the portions of watershed regions that I mentioned before. Now, as important as the arteries are the veins to understand the pathology of these structures. So if you imagine once the blood comes into the spinal cord, then it needs to come out. And the way it comes out is through a pattern that resembles the arteries, but doesn't have the same functional distribution. So you have usually one anterior spinal artery, and you have usually 2 to 3 posterior spinal veins. I'm sorry, these are veins. So the anterior spinal vein is going to collect the blood from the center of the cord. The posterior spinal veins are going to form, again, a coronal plexus that is going to go around and collect the majority of the blood of the cord. It is not very clear if the proportion is the same. Most likely it's not, and most likely the coronal plexus plays a more important role in collecting the blood from the spinal cord. Now, the interesting part of this is that these spinal veins are going to also run out of the spinal cord through radiculomedullary veins. And those radiculomedullary veins are going to follow the nerve roots. And those radiculomedullary veins are going to connect to the larger veins of the epidural plexus. And all of you have done laminectomies and see how big those veins can be and how much they can bleed. An interesting portion of this connection occurs here in the nerve root sleeve. As the radiculomedullary vein comes out and connects to the epidural veins, there is a valve mechanism. And this valve mechanism is determined by not an actual valve in the vein, but by the passing through the dura and by the zigzag connection to the epidural plexus. And that vein is very important. The reason why it's very, very important is because when you have fistulas or arteriovenous malformations in the intradural portion, the pressure that is built in the venous side doesn't usually transmit into the epidural plexus, but it gets to be concentrated in the intradural space. And the majority of the symptoms that these patients with fistulas are going to present is due to an increase in the venous pressure. If we would not have those valves, then the pressure will distribute into this plexus and all the other extravertebral plexuses where the blood drains. And the elevated venous pressure will not be a problem in the pathophysiology of the vascular malformations and fistula. Now, once you get that blood connected to the epidural plexus, it's going to distribute in a very broad manner. And Batson's described 3 venous plexuses that are going to connect actually all the way to the skull and down and into the retroperitoneal space. The epidural plexus constitutes basically the intravertebral Batson's plexus that goes all the way intracranially. So you may find actually in patients with arteriovenous fistulas or malformations distended veins in the intracranial portion, and that is due to the connection that when overcomes the valve and transmits completely into the epidural space can reach the intracranial portion. There is an extravertebral Batson's plexus that is all the prevertebral veins and actually surrounds completely the spine. And there is something else that is the vasivertebral plexus that is basically just horizontal vessels that you see almost in every MRI when you look at them. In the middle of the vertebral body, there's a little vein that goes there. That's the vasivertebral plexus of Batson. And those actually go through the vertebral body and connect the intravertebral plexus with the extravertebral plexus. There's also large veins that go in every foramina that goes from one to the other one. At the end, all this blood is going to be drained by multiple vessels. Actually, the larger veins in the neck that drain the spinal cord are the deep cervical veins. These other ones are the vertebral veins, all of them connected like a plexus and ending in the subclavian veins and the superior vena cava, and in the thoracic and abdominal portion through the azygos, the hemiazygos, the accessory azygos into the superior vena cava, and also through the inferior vena cava. Now, I know it has been a lot of information, but I hope the important points have been clear of these valves, of how the arteries are connected. Then I believe that we can approach the understanding of the angiography of the spinal cord with a better perspective. And this is something that is fundamental when you are evaluating somebody with spinal cord vascular pathology. You need to have very good quality angiograms to do that, and that requires a lot of work. A good spinal angiogram should be complete and the quality should be really superb. If it is not with those conditions, you may very easily miss pathology of the spinal cord. So which are the requirements to have a very good angiogram? Well, one of them is that the patients need to be usually under general anesthesia. You need to have a complete control of the movement of the patient to really be able to visualize the small structures of the spinal cord. Once somebody is going to be doing an angiogram, it's very important that that person is careful enough to do a complete enumeration of the vertebral bodies and a clear understanding of how many ribs are, how many lumbar levels are present, and then a clear denomination of each of these segments. One of the most important things when you're evaluating an angiogram is you need to look at the unsubtracted images and be sure that the spinous processes are centering between the pedicles. If it's not the case, it's going to be very difficult to distinguish the anterior spinal artery from the posterior spinal arteries. And the spinal angiograms usually are going to require global injections here with aortograms that show a little bit of the general map, but more importantly, selective injections of multiple vessels. And those multiple vessels include both external carotid arteries. Remember, the occipital arteries and the ascending pharyngeal can produce vessels that go to the spinal cord, both vertebral arteries, both deep cervical arteries, and both ascending cervical arteries. Then in the thoracic spine, you need the first two supreme intercostal arteries that usually go to the first three vertebral bodies. Then you need selective injections of the other 9 thoracic levels and selective injections of the other upper 3 or 4 lumbar levels. You need also selective injections of both hypogastric arteries, both lateral sacral arteries, and also the sacral medial artery that is a small branch that comes just from the bifurcation of the aorta and extends in the middle of the sacrum. So usually these studies take a lot of contrast, take a lot of time, and a lot of patience. And unless they're done completely, very frequently you cannot rule out totally the presence of an arteriovenous malformation or fistula. And these are some of those vessels that I was mentioning. This is a case that we just did on Saturday, actually. And this patient had, coming from the internal mammary artery, this ascending cervical artery, so it's a chair trunk of the thyrocervical trunk. But the interesting part is, as you can see, some other vessels were opening, and really you have to be very careful in analyzing what are these things. Are these fistulas or are these veins? And what ended up being were basically arterial connections. This was the deep cervical artery. This was actually the pharyngeal artery that were opening through the multiple connections that you can have in the neck. one of the most important goals of doing all those selective injections is that you need to identify the anterior and the posterior spinal arteries. And they have very specific anatomic characteristics, and that's why it was important to review that anatomy before. In this graphic here, what you're seeing is an injection showing the anterior spinal artery. And you see the segmental branch that is going to have the lateral branch is going to be an intercostal. You have the posterior branch that is that musculocutaneous that goes to skin and muscles. And then you have a radicular branch, and that radicular branch is going to be, in this particular case, a radiculomedullary branch. It's following completely the nerve root, gets into the midline, it opens in this hairpin shape, has kind of a Y connection, and produces usually a small superior branch and a bigger one, inferior one. And this one is the anterior spinal artery. Being sure that this is in the middle and that the patient is well centered is very important, but also the shape of the hairpin helps a little bit. Usually the hairpin is a little bit more narrow in the posterior spinal arteries because they're a little bit closer. It's a little bit more broad in the anterior spinal artery. And usually the trajectory of the radiculomedullary branch is slightly higher. This branch that you're seeing behind the vertebral body is the retrocorporeal branch that is connecting actually with the radicular branch from the other side. For the posterior spinal arteries, it's going to be very similar. Usually you don't see too much of the superior portion of the posterior spinal artery. The vessel is slightly smaller, it's towards the side, and the hairpin is a little bit more narrow. Now, one thing is seen it in the drawing, and the other one is in the angiogram, and that can be a little bit more difficult. This one is the posterior spinal artery, and you see it's really very small. So as you can imagine, if there is movement of the patient or the resolution is not very good, you're going to miss it. So you have the selective injection. In this case was in the thoracic spine, the intercostal artery, the musculocutaneous branch, the radiculomedullary branch, and the posterior spinal artery. And this one is the anterior spinal artery. You see the hairpin loop. This one is a little bit more narrow. This one is a little bit broader. This is the anterior spinal artery. This film is well centered, pedicle, spinous process, and the anterior spinal artery in the center. This was at T10, and it was the artery of Adamkiewicz, usually on the left. Now, we have talked about the arteries, the veins, and a little bit about the angiogram. So let's go briefly about the pathology. The best way to classify the pathology of the spinal cord is by thinking a little bit in two things. Where is it located, and what kind of connection, of abnormal connection you have between the arteries and the vein. The type of connections that you can get are basically two. You can have direct connections between an artery and a vein, and usually that is called a fistula. Or you may have connections that are passing through abnormal vessels that form a nidus, just like the AVMs in the brain. Those are arteriovenous malformations. So when we talk about fistulas, direct connection, AVMs, the presence of a nidus. The location can be extradural or can be intradural. If you have an abnormality that is extradural and that has a direct connection, basically you can call it then an extradural arteriovenous fistula. Usually they are traumatic, and I'm going to show some of examples of this. That is not an AVM, it's just a fistula. Now, if you have a connection that is extradural and it has a nidus, the majority of times is not going to be only extradural. It's going to extend also into the spinal cord. If it is completely extradural and has a nidus, then you have an arteriovenous malformation of the bone or the muscle. But the one that is of interest for us are those cases where you have a nidus that extends all the way from the spinal cord, the dura, into the bone, and those are the extra intradural AVMs, also called juvenile or metameric malformations, and those are the type 3 of the Jinjiang classification. Now, if you have an intradural abnormality, they can be in two locations. They can be in the dura or they can be in the pia. If it is dural and is direct, then what you have is an arteriovenous fistula. That's the classic type 1. If what you have is pial and is direct, then you have a pial arteriovenous fistula, and that's the type 4. If what you have is pial with a nidus, then you have an arteriovenous malformation of the spinal cord. And I think that's it. So I believe that in this form of classification is much better and it doesn't become too confusing. And I think it's better to use the terms. So, fistula, AVM, and the location, and that's it. So let's talk briefly about the first type that we mentioned, extradural and direct connection. Those are the extradural arteriovenous fistulas, and the majority of times they occur as a consequence of a trauma. The majority of times they're also in the cervical spine, and basically there are connections between the vertebral artery and the vertebral veins and the epidural plexus. Because of the valve that we mentioned before, the majority of times in these cases, the pressure is going to be transmitted to the epidural plexus, and what you're going to have is mass effect. So these are patients that present almost like if they will have a tumor compressing the spinal cord and the nerve roots. Now, in some occasions, the connection can be so fast and the flow can be so high that the blood that is intended to be going to the vascular artery may be diverted, and they may present with a Steele syndrome. And the treatment, as you can see, can be frequently done with endovascular techniques. Surgery is also possible, but the endovascular technique is very good for this type of lesions. This is a 30-year-old lady that presented with tingling and numbness in the right side. She got an MRI, and in the MRI, the finding was this huge flow void in the T2 on the right side that was putting a significant compression in the spinal cord. And by doing the angiogram, this is a dilated vertebral artery that doesn't end up going into a vascular artery, but rapidly connects into the epidural plexus. And these are the venous faces and some of those radicular veins that are dilated, epidural veins that are dilated. Usually these kind of fistulas are better seen from the other side. You inject the contralateral vertebral artery, and you see here the large connection and the swirl of flow going into the vein. This was an old case. This was treated with balloons, and sometimes what they were doing was putting balloons. Dr. Vinuela has a very interesting picture with almost 15 balloons in the epidural space. The problem with that one is that you are not resolving too much of the mass effect with the balloons. But the goal, of course, is to try to occlude the connection, and this is a direct connection. So you can occlude that connection, you resolve the problem. Today, with the coils, we get a little bit better control of that, but not infrequently, you have to sacrifice the vertebral artery, and that is a good option as long as there is a vertebral artery on the other side and you're sure that the flow is adequate. If necessary, you may do a balloon occlusion test. Now, possibly in the future, we still haven't used it because the cover stents are very small, are very big, and the ones that we have, like the pipeline, probably will not stop the type of flow that these fistulas carry. But in the future, one consideration is to use actually the stents that could divert the flow. And this is a most recent case that I did. Basically, you see the large vertebral artery is almost the same picture than before, very large, and is going directly now into the veins. Nothing goes really above. The contralateral injection with the swirl going into the epidural plexus. And in this case, with coils, we were able to embolize the connection. You don't have any more flow. We have to sacrifice the vertebral artery on this side. This is the vertebral artery in that side. This is basically contrast that is laying down there because it's stagnant. Nothing is going into a fistula or above. And from the contralateral side, you get that there is no more fistula. Now, the second type that I mentioned is still extradural, more frequently involving also the dura and the spinal cord. That is this very large metameric malformations, or juvenile. And they're called juvenile because, contrary to the other ones that we just mentioned that were traumatic, these are usually congenital problems. And they are called metameric because they can be associated with other vascular abnormalities like nevuses or vascular malformations of the corresponding dermatome. And they were initially described by Cobb, that was one of the students of Cushing, and they also sometimes are called Cobb syndrome. And basically what they are these very large, monstrous arteriovenous malformations that don't respect any boundaries and that expand from the spinal cord all the way into the bones or the soft tissues around. They are usually cervical, they're less commonly thoracic, and in general they have a poor prognosis. And this is one of those typical examples. This patient had an obvious malformation in the hand. That was the reason why it was first brought to our attention. But he also had symptoms of radicular compression and pain and tingling and numbness in his arm. When we did the angiogram, he had not only the vascular malformation that had been detected before, but has this large arteriovenous malformation involving the vertebral bodies and the spinal cord. And more recently, I did this other case. It was quite large AVM that was extending almost completely into the psoas muscle, of the very rare ones that invade the lumbar spine. There was very little in the spinal canal and very little in the spinal cord. The portions of the spinal canal I was able to embolize, And I then proceed and embolize a significant amount of the ABM. And this was the result. I was very happy because in general, with exception of this portion, it appeared to be very good. But these are lesions that are very difficult to treat. And the problem is that you embolize some and they recur. And this is the recurrency of that patient. We have now recruited multiple vessels from the hypogastrics and even superficial vessels from the skin, and it had a monstrous ABM. So sometimes you need to do embolizations and surgeries if they're causing mass effect. Sometimes you can combine the multiple embolizations, but these are in general carrying a very poor prognosis, and they're very, very difficult to treat. So how to treat them depends a little bit of where they are, and is basically based on trying to avoid the compression of the cord. Other things probably are not necessarily doing much better. I probably would regret to have treated these extra portions, because what I did was created collateral channels, and I could have concentrated in just treating the portions that were causing compression of the spinal cord. These are being treated now. This actually goes beyond what we do, and some of our colleagues of interventional radiology are planning to treat them through an iliac axis here. Now, continuing with direct connections, these are most commonly in the things that we treat. There are dural arteriovenous fistulas. So these are those that are not extradural anymore, intradural, but direct connections. And probably these are the most common type of arteriovenous abnormalities that we see. They're usually called type 1. The majority of times they're in the thoracic spine, and there's no consensus if this is congenital or acquired. In general, the majority of times fistulas, we have the tendency to think are acquired, and that could be the case, but there is still some controversy regarding this particular type. The primary problem here is that you have an abnormal connection between the artery and a vein, but the connection occurs in the nerve root sleeve. So that's why they're dural. This is not happening in the cord. However, the manifestation is a little bit more difficult to understand, because what occurs is that the arteries connect to the vein, and then those radiculomedullary veins dilate. And once they dilate, they transmit all the pressure into the venous plexus in the spinal cord. So when you do an angiogram, what you actually see is abnormal vessels around the cord. But you should not be fooled. This is not PL. This is actually dural. What you're seeing is the epiphenomenon of the connection. What you're seeing is the distended vessels. But the abnormality lives here. And the best way to distinguish that is when you look at the angiogram, see the place where the first vessel gets engorged. That connection between a small-looking vessel and an engorged vessel tells you where is the fistula. Now, those fistulas can be very complex. They can be in one level, and then some people have decided to call that type 1A, or they can involve multiple levels, in which case they are type 1B. However, these multiple levels are not really connections at multiple levels. What they are dural tributaries that come from different levels and connect at one particular level. And that basically is pointing where the connection occurred. Now, once the connection occurs, the pressure gets to be transmitted into these intradural veins. And as we mentioned before, because of the valve mechanism connecting the intradural veins with the epidural plexus, the pressure doesn't transmit outside. So what occurs is that these patients are having venous hypertension, and the way they present is very unusually with bleedings, but more frequently with progressive myelopathy, because they develop edema and swelling of the spinal cord. And this is also a case that we did recently here. This gentleman had undergone several lumbar images because he was complaining of weakness of his lower extremities and paresthesias. The lumbar spine didn't look that bad. He actually had a laminectomy done for a very small disc, thinking that that was going to improve, and of course didn't improve because the symptoms became worse and he was now requiring a walker to walk. Somebody decided to image the thoracic spine, and the finding was this. You see a swelling of the spinal cord and maybe some swirling structures around, some slightly dilated phloboids, but a lot of swelling of the spinal cord. So remember, this is the typical form in which an arteriovenous fistula is going to present. And this is the same case, and I'm going to discuss it because it allows us to see a little bit of some of the endovascular procedures that can be done and some of the advantages or disadvantages of that. This was taken by some other member of our team here in interventional radiology, and basically what you can see is, I believe this was the T6 level injection, the T6 level injection of the segmental artery, the intercostal artery, and what you see is a small group of vessels. This is the retrocorporeal artery, and then all of a sudden you see this little dilated point that goes up and connects to the cord veins. So basically, to give you an orientation of how magnified this is, the midline is going to be here. The edge of the dura is going to be around here. This shadow shows the vertebral body. So what you're seeing is multiple little vessels that are irrigating the nerve root. Those are little radicular arteries. And then it connects at this point with the radicular vein, that is actually radiculomedullary vein. And then what you're seeing here is the dilation of that vein that is being transmitted to the spinal cord. In the level below, you see the radiculomedullary artery. This is Kiewicz. And from the same branches that were forming the radiculomedullary artery, there were these connections that were traveling all the way above. This point is this point. These arteries that are coming from below are actually, in this case, flowing back retrogradely into the next level. So these are dural vessels that end up connecting at the same point in the dural sleeve to this point where the dilated vein appears. So my colleagues took him to try to do an embolization, and they catheterized selectively the first feeder, and they got very close to this little network of vessels that was going into the fistula and injected one of the new liquid embolic materials. However, the embolization was not successful. It didn't reach. And that frequently happens, and we will see why in a minute. So when you inject the next level, basically what you find is that the fistula is still there. And these things are very resilient to be treated with endovascular techniques. The reason is that the way the fistula is formed, even though it's a direct connection, is through these very small little vessels. So these little vessels cannot be completely occluded even with the liquid embolic materials. And the reason why endovascular embolization was very unsuccessful in the past, and still is in some cases for the treatment of the fistulas, is because of this morphological structure of the pathology. During the 80s, when the only embolic materials that we have were particles, people was embolizing this with the polyvinyl alcohol. The problem is that you may get some of the vessels, and the angiogram look good at the beginning, but when you follow it, they have recurrences. The larger probably paper was 14 cases, and 13 have a recurrency, so that was not very successful. Polyvinyl alcohol and particles are not a good method to treat this because they are transient and they dissolve with time. Then during the 90s, Alex Bernstein and many other groups, including our group here, tried to embolize them with the liquid embolic materials, with the acrylic. And those had a little bit better penetration, and in some cases it was successful. But as you can imagine, you need to take every single one of these branches to really be successful treating the fistula. If there is one of them that you don't embolize and persists going to the vein, you're not going to resolve the problem. And actually, more than the ones in one level, you also have all those dural vessels that are coming from other levels. So you need to reach the fistula to be able to treat it. Unless you get into the fistula and even a little bit into the vein that is connected with the embolic material, you are not going to be able to exclude it from the circulation. So this particular case, we took it to the OR, and what you are seeing here is the icy green intraoperative angiogram. You almost cannot see any of the normal vessels because of the resolution. However, you can see clearly the vein that was being filled. And this looks pretty much like the angiogram that I just showed. This is the radiculomedullary vein that is all engorged in the posterior aspect of the cord. It was actually not anterior, it was dorsal. And this is the level of the connection. So surgically, what you have to do is isolate all that segment, take the feeders that are coming in the dura. You can see here this little branch coming just in the edge of the dura. And once you isolate the vein, you basically cure the process. This is probably like the case that Charles Ellsberg did first that was successful just by taking the vein. And you need to be careful to be sure that there is no other connections. And in this case, actually, a very meticulous study of the angiogram is fundamental to know where to do it, and it doesn't take too long. One of the risks is, of course, that now that the vein doesn't have the amount of flow that I was having before, there is a chance that they may have thrombosis. And actually, just by the end of the surgery, as you can see, the vein was already getting stagnant and thrombosed. The majority of times, the other plexus, the coronal plexus, takes over, and it's not too much of an issue. Now, if the connection is not in the dura, in the dural sleeve, but is in the spinal cord surface, then this is the PLABFs that were originally described by Harris and that are considered the type 4. They're usually located ventrally in the midline. They usually originate from the anterior spinal artery and have a direct connection with the anterior spinal vein. And depending on how big the connection is and how long this has been going on, you may get different degrees of dilatations and aneurysms associated with it. The high flow is responsible for the formation of those aneurysms, and these kind of fistulas can be associated with hemorrhage, but also with venous hypertension. And depending on the degree, they can be subdivided in A, when it's just the direct connection, B, when you have this varix or aneurysm, or C, when they are quite large. And these are three angiographic examples of that. This is an anterior spinal artery. You see a little bit dilated vein that starts going up. A type B, now with a small aneurysm, and a large type C where everything looks quite distended. The form of treatment for these lesions depends of several factors. Where is it located and how big it is? The anterior location makes it a little bit more difficult for the surgical approach. You still can reach them through extreme lateral approaches, especially if it is in the cervical or the thoracic spine. You may consider to do a complete anterior approach, which would require a corpectomy. For endovascular purposes, very small fistulas cannot be easily reached because you cannot pass these catheters into the anterior spinal artery. And those that become larger, not too much like this, but more like this, can be easily reached and treated through endovascular techniques. However, remember, you are going to have to sacrifice that little segment. So there is always a risk that by doing the endovascular treatment, you actually may produce a stroke in the spinal cord. So the treatment of this requires really a very good understanding of the anatomy and a consideration of the risk of the location to decide if it's better with endovascular techniques or with surgery. Now, if we move to not direct connections, but lesions with the nidus, the main lesion with the nidus are the intramedullary arteriovenous malformations. And they're basically very similar to the ones in the brain. They are the classic AVMs, also known as glomus-type lesions. They can be fed by the anterior spinal artery or by the posterior spinal arteries, and they usually have two patterns, those that are very compact or those that are more diffuse, and they can have multiple feeders from different regions. These kind of lesions usually are characterized by high pressure and high flow with low resistance, and they are the ones that present with bleedings, not too much with venous hypertension, even though that can occur. So this was a 30-year-old guy. He had a very severe headache. He lost consciousness and fell in the shower. He had a subarachnoid hemorrhage. The CT angiogram was negative. The angiogram was negative. The cervical spine MRI was negative. But he also had in the past some complaints of lower back pain, and his lower back pain was persistent. So the initial workup was negative for anything abnormal, and follow-up workup with an MRI of the thoracic spine showed that lesion, that is this very large arteriovenous malformation. And as you can see, there is this abnormal connection between the arteries, that is this one, and the vein, and this is the nidus. So this is a classic AVM. Now, the treatment of the arteriovenous malformation is also complex, and it can be done in different ways. If you have probably small arteriovenous malformations that are incidentally found or asymptomatic, you may consider, because the majority of times they're anterior, just treatment with radiosurgery, for example. If you have patients that have a bleeding, there is a risk that they may have bleedings again, and then you may have to consider to be more aggressive in the treatment. Those treatments can include a combination of embolization with surgery or embolization with radiosurgery. The embolization sometimes can get completely the AVM, but it doesn't happen all the time. This particular case, for example, was also embolized, and as you can see, only the inferior portion was safely taken. The superior portion was not taken, and this patient is actually being followed by Tony, that I think you radiate him. Now, if you decide to go for the surgery, there are several important things that need to be taken in consideration. You should be sure to have intraoperative monitoring with somatosensory and motor evoked potentials. A very careful analysis of the angiogram is important. You need to be absolutely sure that you are localizing correctly the level. And if you have somebody embolizing, putting markers in the arteries that were embolized, like little coils, or using the embolic material can be useful to be sure that you are in the right level. The main goal is to preserve the anterior spinal artery, and that needs to be done meticulously. And the dissection needs to be done sharply without using too much coagulation, because the heat injury can produce damage of the cord. So these are lesions that are not easy to remove, but when somebody has had a bleeding and has symptoms, it's probably the best way to try to treat them. Now, the approach needs to be adequate, and you need to have enough exposure to be sure that you're going to be able to take it completely. And probably, if possible, it would be useful to have intraoperative angiograms of good quality, or doing it immediately after the surgery to resect them. Now, the role of radiosurgery in this kind of lesions has been growing, and the Stanford group has published already several papers regarding this. This is one of those cases that they describe, a patient with an arteriovenous malformation in the cervical spine. This is the original scanned presentation. Then 1 year after fractionated radiotherapy, I think they did. Do they do fractionated? Yeah. Hypofractionation. And then at 3 years, the main concern is, of course, the effects that radiation may have in the cord. The results have been positive, but still, usually the best approach is to try to add the factors. Where is it located? How big it is? How reachable it is from the endovascular perspective? If the endovascular techniques are going to be used, they should be with a clear goal preoperatively or before the angiogram. Partial treatments with embolization are probably not good enough and doesn't necessarily change the natural history of these lesions. And also consider the role of radiosurgery. Finally, in the last minute, I wanted to mention the classic Foin and Alain-Jonin syndrome, that basically is this subacute progressive myelopathy that usually male patients, usually older than 60%, and that is very frequently misdiagnosed for other reasons. These patients have very frequently multiple scans of the lumbar spine. They even go for surgeries. As you know, 30% of normal people can have abnormal MRI spines, and it's not until they become progressive paraplegic that frequently these lesions are discovered. And basically what occurs is that usually with arteriovenous fistulas and less frequently with arteriovenous malformations, all that venous hypertension produces damage of the veins, and the vascular structures become fibrotic and thick, and the venous hypertension produces venopathy that ends up producing thrombosis. The thrombosis of the veins induces necrosis of the tissue of the spinal cord, and this is the images that you will find in these patients. This is an MRI with a T2, and in the T2 you see these hyperintense lesions in the veins and dilated tubular structures of the spinal cord, and this is the typical pathologic findings with thick fibrous vessels that are thrombosed and coagulation necrosis of the spinal cord. In addition to the lesions that we have mentioned, remember there are some other tumors and vascular abnormalities, some of them in the past considered tumors, that almost need to be treated like arteriovenous malformations from the surgical perspective and from the angiographic perspective. Hemangioblastomas are one of those tumors. They represent around 1 to 5% of all the spinal tumors, usually nodular with enhancement, very richly vascularized, and the pattern in the angiography is this delay kind of enhancement. You can embolize these tumors before resect them, and when you resect them, you need to treat them like an AVM, sharp dissection, preservation of the anterior spinal artery, careful monitoring, and meticulous surgical techniques. And we're going to have another conference for cavernous malformations, and then we will go into more details on that. But these cavernous malformations are also some of the vascular abnormalities of the spinal cord, very controversial regarding the treatment. Most likely, if somebody has symptoms or has bled, it's a good idea to resect them surgically. But you need to consider also the location, how superficial they are before doing that. And this is actually a case that I did with Neil many years ago. And this was the lesion. It was really tiny, and as you can see, very meticulous resection is very important. Frequently, they are associated with very small venous anomalies, and the preservation of that anomaly is fundamental. You cannot see them in the angiogram. and they're very difficult to see in the OR too. And that's it for now for the vascular lesions. So you're invited to talk about to discuss with me the cavernous malformations in a future session. Does anybody have any question?